Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Saramelli, and I oversee Grand Rounds for the department. I want to say just a couple of things about the Grand Round series generally, and then I'll introduce today's speaker. So I encourage you anytime during the presentation today, write in comments or questions into the chat or the Q&A, and I'll collect those and go through those at the end with Dr. Das. I've mentioned this before, there's an expanding group of people working on Grand Rounds series this academic year, partly because once a month, we're going to resume having in-person Grand Rounds, which will be a hybrid event the first Friday of each month, starting in November. And Charles at Harborview is joining the Grand Rounds core team to work on that, along with Mike continuing to work on technology and Samhar on coordination and communications. There's several sources of funding for this year's series, including the Ripley Fund, the Garvey Institute for Brain Health Solutions, and the Treatment of Mood Disorders Fund. With that, I'll say a little bit about today's presenter. Today's presentation is by Dr. Smitha Das. And Dr. Das is a clinical associate professor and addiction psychiatrist in the Stanford University Department of Psychiatry and Behavioral Sciences. I think that Dr. Das's educational background, we were just talking about this a couple minutes ago, is interesting and led to some very, I think, unique projects and perspectives. Dr. Das completed an MD PhD program and an MPH, which in that context included a very interesting dissertation project related to using randomized trial methodology, but looking at hospital systems and how hospital systems were performing on addressing tobacco use treatment in their health systems. I think a project that's very representative maybe of blending these different disciplines and consistent with Dr. Das's interest and expertise in addiction. Dr. Das has over 2 decades of experience in research in healthcare quality and addiction, and has worked nationally, including in the American Psychiatric Association. I have a prop for the presentation here, which is an article from the Psychiatric News on the presidential special section or theme this year for the APA, which is on addiction. And Dr. Das led, it seems, the first quarter of that on vaping and tobacco use. Dr. Das has also worked locally in the California Psychiatric Society and has been a past president of the district branch there. We're very fortunate here to have Dr. Das presenting in our Grand Round series. I'll stop there for now and turn it over to Dr. Das.
Fantastic. Thank you so much for that warm introduction. I'll go ahead and share my screen. Great. Well, I'm delighted to be here and really appreciate the invitation and the warm welcome from our colleagues here. And I am also very excited to be talking about this topic because of how important it is and how relevant it is to psychiatry and mental health. So I like to open often when I'm talking about this topic with kind of especially in addiction circles, a bit of a statistic that can be jarring, and that's that smoking causes more morbidity and mortality than alcohol and all other drugs combined. And so this is something that is, again, very relevant, very impactful to our populations. And I'll talk a bit about why that is, but also not just all of the bad news about smoking, as well as vaping, but things that we can do in our practices, in our systems to try to address this issue. I will say that I don't have any relevant conflicts of interest. I do work at a company called Lyra Health, and that doesn't have anything to do with this presentation. So after this presentation, I hope that we'll be able to talk about the importance of tobacco cessation treatment in addiction and mental health settings, review a bit about the epidemiology, nicotine pharmacology, so that we have an understanding of why this is such an important substance use disorder to consider, and then also think about newer products such as e-cigarettes and a special highlight on youth, which in that particular Psych News highlight or report, youth were an important population. And then finally, I'd love to leave us with some brief quit strategies and resources to learn more, not just about how to treat this and address this in your individual practices, but also how to think about this from a systems point of view. Many of the slides that I have here come from rxforchange.ucsf.edu, which is where I did some of my training, and these are freely available so that if you are interested in training your trainees or your systems or your clinics on tobacco cessation, or they're there, as well as several of the handouts that I'll be referring to. All right. So there's many factors that contribute to tobacco use, and we'll review some of the biologic and pharmacologic. There's obviously a genetic predisposition, as with any medical disease, but also things like the issues that relate to the withdrawal and the pharmacology of nicotine. There's a psychological and behavioral aspect. So even once somebody is able to move past the physical withdrawal symptoms, they have been conditioned to use smoking in certain situations. And a lot of what we do in CBT and return to use prevention is in working with those specific triggers and situations. I think it's also very important to talk about how there was a systemic and treatment aspect of prolonging tobacco use in our patients. And that has to do with the institutions that promoted tobacco use over time. And unfortunately, that still does exist in some places today. And so examples of this, which there's an excellent resource at UCSF in the legacy documents, where tobacco company documents are required to be placed. Examples of this are, for example, the National Institute of Mental Health related hospitals in several decades ago would request for cigarette donations so that they could use them as rewards for their patients. A lot of other examples involve how in mental health and psychiatry, there was a conditioning of and an understanding of how it is to smoke with your patient, how it can make it easier to work with them if a treatment provider or staff member were to smoke with them. These are luckily things that are reducing in prevalence now. And as I said, in some pockets of the country, some of these practices or traditions do continue. And so a lot of these systemic and institutional ways of promoting smoking in mental health and substance use disorder populations led to disparities. So while anywhere from 20% of the population uses a tobacco product, and the percent that uses cigarettes is anywhere from 11 to 13%, depending on the most recent survey, we do have an increase in e-cigarettes. We also know that people with a mental illness or substance use disorder smoke at much higher rates, consume almost half of the cigarettes in this country, and account for almost half of the premature deaths annually. As I noted, smoking accounts for more morbidity and mortality than alcohol and all other drugs combined. So while as a nation, I'm very excited to be a part of a movement to get awareness out there about substance use disorders as part of the presidential initiative at the American Psychiatric Association, I'm leading a team of folks who are working on various topics from vaping. This quarter, we're working on opioids, then we'll focus on alcohol and then technology. Opioids, for example, have a lot of attention. Obviously, it's devastating what's happening with overdose risk and so on. And at the same time, the number of people that are dying from opioids-related deaths, as well as opioid use disorders, much less than tobacco still. And so, while this is something that tobacco is something that we've faced as a nation for a long time, it is still very important and very impactful. I also wanted to highlight that the overall percentage of people using cigarettes is at 11 to 13%, depending on the survey, but it does vary from geography to geography. So over in Washington, it's going to be lower than many other places in the country. And I find this too, being from California, when I'm traveling for conferences and so on, just being struck by how much both cigarette and e-cigarette use there is nationally. I've mentioned already, tobacco is the leading preventable cause of death in our country, and people with mental illness and substance use disorders are disproportionately affected. And this can really impact mental health settings. And so for a long time, it was that psychiatrists and others working in mental health settings said, well, that's not my problem. That is something that it's going to take away from what I'm treating. It's going to make the outcomes of somebody's depression or other substance use disorder worse. I don't have time to deal with tobacco. That's somebody else's problem, maybe the primary care doctor. But it's really important to think about how the outcomes that we are interested in and what our goals are with our patients, how those are affected by tobacco. So tobacco impacts treatment. So hospitalized people who smoke are more likely to leave against medical advice if withdrawal is not treated. And we've all seen this. We've all been in an inpatient setting. Somebody is very agitated and maybe that order set, luckily we now have these more automatic order sets, wasn't put into place where nicotine replacement therapy was provided. And so, leaving AMA is important, but also these other outcomes such as slightly higher rates of Ativan prescribing, as well as seclusion when somebody is not treated for withdrawal, because it's very uncomfortable. We'll talk about the specific components of withdrawal in just a few slides here. The concern that psychiatrists and mental health providers have when it comes to recovery, that people who smoke are going to have a more difficult time quitting other things, or it's going to get in the way of their, being able to have recovery overall. A systematic review found that people who smoke with current and past alcohol problems, yes, generally are more nicotine dependent. That makes sense. Are less likely to quit, but are as able to quit as smoking as individuals with no alcohol problems. So while they are less likely to make that quit attempt, if they do make that quit attempt, they are able to make it. And especially with extra assistance, they can be very successful. We also have this concern of other outcomes being impacted, like abstinence from alcohol and other drugs. But what we're finding more and more in research as we get more of these studies is that quitting smoking makes it more likely and that somebody will remain with their goals that they have for other substances. One concern is that my patients aren't ready to quit. They're not interested in quitting smoking because they're dealing with all these other things. But what we know, again, from the data, is that people with in mental health settings who are interested in quitting smoking are just as likely to want to quit smoking. They may have more difficulty quitting smoking, but they are just as ready, if not a little bit more in some settings, to want to quit smoking. So that's not a reason to not approach this topic with our patients. There are obviously, we all know the benefits of quitting smoking, so I'm not going to belabor this point, but I do want to touch on the idea that, well, I have this patient who's smoked for decades. Why should I bring this up now? They're struggling with something else. They're struggling with psychotic symptoms. They're struggling with major depression. Why should I bring this up now? It's not going to do any good. And we have very clear research that there are incremental benefits from quitting smoking at any point, and that people do realize this. I run a smoking cessation group at Stanford, and it's always delightful. I think about when I know that somebody has quit smoking about 3 weeks later after they're able to kind of expel a lot of the phlegm and build up, and the cilia in their lungs start to grow back. They have this new take on what it's like to breathe, and it's lovely when a group member shares that every so often, because it's something that's motivating to the rest of the group, and it's a real tangible, concrete benefit of quitting smoking. Something else that I like to highlight is, while there's less promising information when it comes to the lung with heart disease, people who are able to quit smoking are able to return to the risk of heart disease of that of a non-smoker over time. And so that's very motivating too. I like to remind my patients that there's no safe level of smoking. So sometimes in mental health settings, it may be, well, they're just having a few cigarettes a day. Do I really need to bother with that? It does impact their health outcomes. And at any point in somebody's life, there is a benefit to their lifespan, not to mention, as I said, elements of their quality of life with quitting smoking. So our patients, those that are in mental health and psychiatry settings, are affected by tobacco. They are disproportionately affected, and they do have hope that they can achieve excellent outcomes when it comes to being able to quit or reduce their smoking. And they are just as likely to want to quit compared to the general population. So with that in mind, we'll talk now about how what forms of tobacco there are, and we'll pay special attention to vaping because that is a relatively new topic from the last 10 years. Here we go. So cigarettes. Cigarettes are obviously the most predominant form of tobacco that our patients use still. Shortly thereafter, we have things like smokeless tobacco, pipe cigars, and then as we go down this list, there's less prevalence. But electronic cigarettes at the bottom of the list, that's the new wild card, or relatively new wild card. So these are in general tobacco smoke, we have many chemicals, and we'll talk about the vaping devices in a moment, but we have many chemicals, many of which are known to be cancer-causing agents. And so I think everyone is well aware that cigarettes are harmful. They have cancer-causing agents. That is not surprising. Sometimes though, we may talk to our patients and we may have them say, well, I'm just smoking the light cigarettes. And the light cigarettes, oftentimes, while they may be marketed as being light, the way that our patients smoke them, in particular people with psychiatric diagnoses, we know from research that they actually do smoke them in a way that kind of undoes that whole lightness about them. So a light cigarette has, for example, an extra row of ventilation holes. But in general, for example, in studies that are looking at people who have schizophrenia, they may hold their cigarette in a way that they end up covering up those extra holes as well as the original holes. And so the amount of nicotine and chemicals that is taken into their system is increased. So in some ways, the light cigarette is a marketing way of making something look safer, but they aren't actually necessarily safer. And any amount of smoking, as I mentioned earlier, is harmful. Moving on to e-cigarettes. So e-cigarettes can look like cigarettes. They can look like USB sticks. They can look like these more large devices down here at the bottom. There's many names for them: vapes, vape pen, e-cigarettes, ENDS is electronic nicotine delivery system, and their popularity has been growing. We hopefully are reaching more of a plateau, but there are more creative marketing mechanisms that the companies are coming up with to try to market these things as health related or good for you, or naturally energizing and so on. And so while we have had interest in these, the peak population are young people, generally people who are in their teenage to 25-year-old years. And so this transitional age youth is really important when it comes to e-cigarettes. They're powered by either a rechargeable or disposable battery. The cartridge that's put into them can have an array of chemicals. And so propylene glycol is one of the ones that's concerning, as is glycerin. Many flavorings, flavorings that are appealing to youth. We have the same sort of discussion when it comes to cannabis edibles. And the nicotine really can vary. A really important study on e-cigarette cartridges found that those that are labeled as not having nicotine did have nicotine, and the percentages of nicotine really varied. And while this is technically supposed to be a regulated industry, the amount of regulation and the amount of loopholes really does vary. So it may be that a company finds a way to sneak in a flavoring in some way, or if something is refillable, then they can get away with selling solution for refillable, because a lot of the regulations apply to pod-based e-cigarette devices and so on. And the way that the product works is that either that pod or that cartridge that has the refillable solution, it gets heated up and it vaporizes the liquid, and that then is inhaled and can affect the lungs as well. And so in ways that it can affect the lungs, I mentioned propylene glycol is concerning. It can cause respiratory irritation, increase the risk for asthma. Several of the flavors can cause pulmonary injury. And then, of course, there's just the nicotine that's in the products, which is highly addictive, one of the most reinforcing substances that is out there. And these flavorings can be attractive to kids, or if they're refillable solutions, which again can get through some of the loopholes of the regulations. Kids may find this to be, a colored solution with a fun name on it, and we have seen that nationally there has been increases in poison control calls related to these solutions. So they're not proven to be safe. We still have a lot to learn about e-cigarettes, and as I said, at the same time, many of the companies are touting them as ways to quit smoking, which we'll discuss in a moment, but also as these kind of health type products. Let's focus on people with mental health concerns. Again, thinking about the group that's here today that is part of this discussion. So in adolescence, e-cigarette use is associated with depression, SI, and a history of suicide attempts. In adults, if we look over at this graph here, what we see is we have people that are either that have no mental health condition or mental health condition. And we find that people with a mental health condition have had either ever use or current use of e-cigarettes. But also if they smoke, then that's even more pronounced. So people with mental illness and who are using traditional cigarettes do use e-cigarettes at a higher rate. And this is important because dual use can just increase the amount of nicotine somebody is taking in, and the use of one, meaning e-cigarette, can reinforce the use of the other, the traditional cigarette, and it can be a dangerous pattern. So can we use these for smoking cessation? Now, there are some countries that have approved some e-cigarette type devices for smoking cessation. I will say that those are in very regulated type situations where the device is known and there is a desire to just reduce smoking overall. And so the idea is to have the e-cigarette, this more regulated e-cigarette, be a part of that. We don't have that case in the United States. And I'll talk about the two most recent reviews that look at e-cigarettes for smoking cessation, because of course there's many individual studies. There was a very widely publicized JAMA study around this, but the 2022 Cochrane review looked at e-cigarettes versus nicotine replacement therapy, and quit rates were higher in people randomized to nicotine e-cigarettes compared to non-nicotine e-cigarettes, quit rates were higher for those who use nicotine e-cigarettes than nicotine replacement therapy, and nicotine e-cigarettes compared to non-nicotine e-cigarettes. So this was building up some of that evidence or desire to have nicotine e-cigarettes for smoking cessation. In many of the well-done studies here, in particular that JAMA study that is included in this review, is the use of e-cigarettes is different from nicotine replacement therapy. If I have a patient and I give them a device that looks like an e-cigarette and is an e-cigarette, then they're more and looks like their actual usual mode of getting nicotine, which is a cigarette, they're more likely to use that. Whereas if I talk to them about using nicotine replacement therapy, first, a lot of people don't use nicotine replacement therapy correctly. But second, it's a lot less interesting for them to use it. And so what we saw in these studies is that while folks did have a better chance of being able to reduce their tobacco or their cigarette use with e-cigarettes, they were using the e-cigarette a lot more than the nicotine replacement. And the nicotine replacement is only effective if you use it. And so so this is a part of the push of trying to talk to clinicians about really having that discussion with your patients about how to use nicotine replacement therapy, and reminding them that the medication is only useful if you use it. Another review that was in preventive medicine looked at e-cigarettes, and I think what's notable about this review is that people continued to use e-cigarettes for a long time, more than 6 months, and greater than how long they were recommended to use in some of these studies. Even people who were not randomized to e-cigarette arms then also started to use e-cigarettes and use them for more than 6 months. And I think that brings up this question of what are the long-term impacts? What happens over time if somebody's using an e-cigarette and continues to use an e-cigarette? And because these devices really became very popular starting in 2013, we don't have enough of that data. And so I think it's important for us to consider what might be the outcomes, say 20, 30 years down the line. Now, my hope is that everything will be fine and people will be fine. But what we found over and over again in public health is that sometimes that's not the case. So I like to refer to this resource. NASM has put out several very good summaries on issues. One of them is cannabis, but another one is on e-cigarettes. And they have stated that there's conclusive evidence that e-cigarettes are harmful from a nicotine and particulate matter, not secondhand smoke, but particulate matter point of view. Exposure to nicotine is variable. They have potentially toxic substances and carcinogens. They can explode, especially when they're of poor quality. So as we see more regulation of devices in the US, are people going to be going to lower quality products to try to get around those regulations? And that completely substituting e-cigarettes for combustible tobacco cigarettes may reduce exposure toxicants than those present in traditional cigarettes. So when a patient comes and says, look, I want to use an e-cigarette, I will say, let's make sure we have two solutions or two items in place. And this is after we've made sure that they've tried evidence-based methods of quitting smoking, and that we are able to work on a plan together. So one of those things is that they don't use both at the same time, because as I mentioned, dual use is concerning. But second, that they set a quit date for that e-cigarette, because as we're seeing in more and more of the research, people are prolonging their use of e-cigarettes. And I've had several patients in my smoking cessation clinic who went to e-cigarettes, continued using it, and then kind of switched back into traditional cigarettes, and they keep doing this merry-go-round. So the consensus is that we should encourage folks to quit smoking in whatever way they would like to, and definitely try evidence-based ways first. And if somebody is set on using an e-cigarette, then working with them to have those two things in place: no dual use and setting a quit date for the e-cigarette. I also like to be open that we don't know entirely about the safety profile. So if they tell me, well, I'm using this device, and they give me a lot of details about it and brand names and nicotine concentrations, I'm very open that, like, there's while these are technically regulated as tobacco products, there's very little standard information that we have about the safety profile. When it comes to youth, it's important to remember that nicotine can act as a gateway drug. What we're seeing in youth is that kids aren't necessarily going from tobacco to trying to quit cigarettes with an e-cigarette, as I just mentioned. They're usually starting with the e-cigarette. And it is associated with a greater risk for subsequent cigarette smoking. So this is a new concern. This isn't anything about the debate of whether or not e-cigarettes can help somebody quit smoking. It is concerning that young people are starting to use nicotine products with e-cigarettes. It's also interesting to see where these jumps happened. They're with e-cigarette industry milestones. A lot of the e-cigarette companies are part of larger tobacco companies, and so they're using a lot of the same science methodologies and so on to increase use. The PATH study is an excellent set of data that are producing more and more data, more and more research around this topic. So I'm going to focus first on figure 1 here. So first tobacco product used is e-cigarette among young people. This is happening more and more over time. It's not traditional cigarettes or cigars, so on. It is the e-cigarette. And then the frequency of use is increasing. So while it might have been that in a day, in 1 to 2 days a month was where people were more using the e-cigarettes, now 30 days is increasing over time as opposed to less frequent users. And then finally, a severity of dependence. So for cigarette smoke, smoking, we generally use something called a Fagerstrom test for nicotine dependence, which has several questions on it that look at how dependent somebody is on a cigarette. And one of those questions is how soon do you smoke within waking? And if somebody smokes within 5 minutes, they are highly dependent on cigarettes. And we're seeing that with e-cigarettes, people are now increasing. The number of people smoking or vaping within 5 minutes of waking is also increasing. And so, in the future, may we have a proxy or some sort of extension of the Fagerstrom test for nicotine dependence that has to do with vaping. So, these are newly regulated, but we need time to actually have that be more meaningful, and there's many loopholes. Things like EVALI have been concerning. I'll talk about that in the next slide. Many countries have banned e-cigarettes. I already said what we should do. What is the CDC summary statement about e-cigarettes, that we shouldn't recommend them as primary cessation aids, but it is reasonable to support an attempt with those conditions in place. And while harm reduction is being researched, concerns about youth and new users is concerning. EVALI. So EVALI was something that happened actually right before I think the pandemic really peaked. The news went away shortly after most of the shutdowns had happened. But there was this lung injury, and people were getting hospitalized at alarming rates, and it was related to the use of these products. Now, the reports on EVALI haven't fully said it's this or that, but generally the idea is the consensus is that likely vitamin E acetate, which is in cannabis oils, was the culprit in leading to all of these hospitalizations. And luckily those have tapered off, but it's one of those public health learnings that hopefully we won't have to revisit again, but we should remember that this was a finding that was related to the vaping products. While I'm talking about cannabis, I am going to talk about cannabis vaping and youth again, because I think this is very important. So 1 out of 5 e-cigarette using adolescents uses that device to smoke cannabis oil. And these devices often allow them to have greater absorption and THC dose, especially because they can use super concentrated cannabis or THC concentrates rather in these devices. And that is allowing them to have greater delivery of THC compared to, say, smoking a rolled paper joint. Lifetime prevalence of cannabis use is increasing, and the majority of those adolescents who have ever used cannabis report having vaped it. So e-cigarettes are relevant to cannabis and also relevant to our youth, increasing rates. So cigarettes are the most common form of tobacco, but e-cigarettes are increasing in popularity. They're not safe or known to be completely safe. There may be hopefully some promise one day of understanding the impacts of vape devices on smoking cessation. But at the same time, youth adopting these products early and also using for cannabis purposes needs to be prioritized so that we can reduce exposure over time. Okay. So I've mentioned already that nicotine is highly addictive, and I've given hints as to why, but we'll go through a few slides to really drive that home. So when somebody takes a puff of a traditional cigarette, nicotine is able to have impacts on the brain within about 11 seconds. That is a drug that is highly reinforcing. Somebody uses it, they get an immediate effect, and we'll talk about what those effects feel like, and that makes them want to use it more. Another thing I think that's just useful to know, this tends to be one of those boards things, is that nicotine is able to be detected in cotinine in the urine, and so that it breaks down into cotinine and other metabolites, and cotinine is what we can detect in the urine. So I said nicotine produces all of these effects that feel positive, and these are all of the neurotransmitter systems that we are aware of in psychiatry and that we work with often. And these all are things that feel good, right? So nicotine impacting dopamine, increase in pleasure and appetite suppression, reduction of anxiety and tension, mood modulation, cognitive enhancement. Many of my patients talk about how it's what allows them to work and focus and concentrate. And these all look like great things, right? These are all, if somebody said I could have a magic something that would help me with all of these things, I'd say, where do I sign up? And unfortunately, nicotine, in addition to all of the negative aspects of tobacco smoke that I discussed in the previous section, also has the impact of having withdrawal. So once the nicotine reaches that peak, it then drops pretty quickly. And these are the things that are experienced in withdrawal. Irritability, frustration, anxiety, depressed mood. These are symptoms that oftentimes our patients are coming to us for help with. And so it's really hard to piece apart what part of this might be nicotine withdrawal, or maybe we don't even think about that because we really want to go and treat the anxiety and depression as we should. And it's important to think about if nicotine withdrawal is part of that complex picture. What I like to remind patients, but also other clinicians about, is that these symptoms will show up within a couple of days, peak within a week, and then subside in 2 to 4 weeks. And there I'm trying to provide hope that the physical urge and the withdrawal, that physical aspect of it, should resolve in about 4 weeks. Now, there's obviously a behavioral component, and we'll talk about that in a moment. That behavioral aspect can continue for a long time because that's harder to unlearn. But the chemical withdrawal aspects of the nicotine will resolve within 2 to 4 weeks. So this is an image of how the cycle of nicotine addiction happens. So there's nicotine that is, plasma nicotine is very low in the morning, unless all of us have had patients that will get up in the middle of the night to have a cigarette. But for most folks, plasma nicotine is very low in the morning. Somebody has that first cigarette. They get all those good feels that I just showed on the previous slide. And feel great, but then very quickly that nicotine concentration drops. And so then they start to feel the impacts of that withdrawal. And so the response is to have another cigarette. And this continues roughly 20 times a day, which is a nice round number, and also a nice round number that tobacco industry has found to be the perfect amount for a pack of cigarettes. And so somebody has their 20 cigarettes, they go to sleep, and then abstinence symptoms kick in. And then first thing in the morning, if they're highly dependent, as I said, with smoking within 5 minutes is one of those markers, they have their first cigarette. So when somebody is smoking, at first, the nicotine goes and gloms onto the nicotine receptors. Over time, though, what we see is that these receptors get pitted into the structures, and so they're able to then upregulate. Let's see here. Yep, they're able to upregulate over time after getting pitted in. And so with that upregulation, when somebody stops smoking entirely, then there's all these new receptors that are expecting nicotine and they don't feel it. And this leads to some of the feelings of withdrawal. Another thing that I like to remind us when it comes to nicotine pharmacology, and this actually has to do less with the nicotine and more with the tobacco smoke, is that oftentimes many of the drugs that we may be prescribing have a decreased effect due to induction of CYP1A2. And so I want to be very clear. This is related to the cigarette smoke and not the nicotine, but it is actually very clinically relevant because I have had patients who have taken up smoking, and the medication levels of for example, their Haldol, their olanzapine, and in the most devastating case that I have had, clozapine levels dropped dangerously low, so that their symptoms weren't covered anymore. The other one is caffeine. So in a lot of our treatment settings, people are drinking coffee. They may be in an IOP, they may be in groups or residential, and there's coffee and the coffee is flowing. They may have 8, 9, 10 cups of coffee, and they're going out to smoke because unfortunately a lot of treatment settings still allow for smoking at a smoke pit. And so the caffeine, they're not feeling the effects of the caffeine as much because they're still smoking. When they quit smoking, suddenly the effects of the caffeine that they'll feel are much higher. And so they're going to have caffeine intoxication, which can lead to being jittery, anxious, and so on, in addition to nicotine withdrawal. So those two things combined are very real. And I like to remind patients, you may want to cut down on your caffeine if we are having you quit smoking. I mentioned RX for Change website earlier, and I said that there are handouts. One of them is just this 2-page quick reference that can show you the pharmacokinetic related drug interactions. So tobacco products are effective delivery systems for the drug known as nicotine. It's a highly addictive drug. It's very effective, and it works on many neurotransmitter systems. The interactions result from the smoke and not the nicotine. So if somebody's using nicotine replacement therapy, we don't have those interactions. And because this is such a complex phenomenon of nicotine pharmacology, as well as I mentioned, behavior and so on, we need to approach from a multifaceted treatment lens. And so that's what we're going to conclude with, is how do we approach this from psychosocial as well as pharmacologic? So the most recent tobacco treatment guidelines did not really change with their update, aside from including newer medication. As we talked about earlier when we were talking about nicotine withdrawal window, the physiologic addiction to nicotine is generally limited to that. The withdrawal is limited to that 4 weeks. People may feel the urge to smoke after, but there is a large behavioral component. And so that's where it's a 2-part problem, and it's important to address both the physiologic and behavioral. However, I will say, if you're not able to address the behavioral, at least, or the physiologic, at least doing one of them is very important. And so it may be that somebody isn't able to prescribe, that's fine, work on the behavioral. If somebody doesn't have the bandwidth to do the counseling aspect of it, that's fine. Let's at least prescribe some medications to help somebody quit smoking. So the approach to quitting smoking is very similar to other substance use disorders. We want to make sure somebody is ready to quit. If they're not ready to quit, we want to do motivational interviewing and enhance their motivation. If they are ready to quit, there's many frameworks of how to approach this. The Public Health Service guidelines have the 5 A's. I don't care which method we use sometimes, and I didn't get a chance to give a shout out, but a mentor of mine that's part of UW is Andy Saxon, who is just such an expert in this area. And he and I and another one of our colleagues, Doug Zidonis, may have a different methodology of providing treatment, but it doesn't matter which methodology as long as we're using something. And so this is the 5 A's is used for the Public Health Service recommendations. And if somebody has quit in the past, congratulate them, as well as if they haven't smoked yet, because again, our patients and people with mental health related diagnoses are more likely to smoke. And so if they haven't, or if they've quit, that's excellent. So the 5 A's are ask, advise, assess, assist, and arrange. Ask about tobacco use non-judgmentally, advise a user to quit, and then assess their readiness to make a quit attempt. I like to point out this is a little bit MI inadherent, where we're giving advice before seeing if somebody is actually interested in making the change. But because this is such an important public health issue, it's important to make it clear that we want our patients to quit. Assist with a quit attempt, and then arrange follow-up care, because that can really increase the efficacy of this trial. The only other thing that I will say with the assist is that this is actually a lot to cover in just 1 hour. And so again, RX for Change has some excellent slides, and I'll share a resource at the end that we put together just this year to help with tobacco cessation that goes into each of these areas more closely. If someone doesn't have time, as I said, I would not throw out tobacco cessation. In general, I would say, let me do what I can. And so a briefer version of the 5 A's is ask, advise, refer. And I think of this a little bit like screening and brief intervention. We know brief interventions are effective in substance use disorders in general, for example, with alcohol. And if somebody doesn't feel comfortable with going for, a full out intervention, what I would say is ask, advise, refer to other resources. Smokefree.gov is an excellent resource and has quit lines. There's quit lines for the entire country, and that can be the counseling aspect of it. If somebody is able to recommend medications or prescribe medications for treating tobacco, then integrate that too. And I would also give a plug for including this in our assessment and plan, because it's very easy to do this piece and then forget about it. And if we come back and we ask the patient, hey, how's it going? We talked about this last time. Were you able to access any of those resources? That adds to that motivation, and it adds to the salience of how of this topic in your clinical interaction with them. Pharmacologic approaches. So in an hour, I'm not able to go over all of the medication approaches, and that's where I will point us to the resources. But I will say that there are 7 FDA-approved medications that we have for tobacco use disorder, and they're all very underused. And so they should be considered in all quit attempts because they significantly improve the success rates. This is a very non-readable handout that I have here. This handout, again, is available on RX for Change. In fact, you can probably Google RX for Change Pharmacologic Product Guide, and it'll come with this 2-page sheet. And it outlines the 7 medications. The 7 medications include 5 nicotine replacement therapies and 2 prescription medications. And of the 5 nicotine replacement therapies, there are 3 that are over the counter: the gum, the lozenge, and the patch. And each of them has some nuances about how to use them. For example, many of our patients will use the gum and feel the urge to just chew the gum, because that's what we do with gum. We chew it. It's chewing gum. But with the nicotine gum, one must chew it until there's a tingly, peppery feeling, and then park it in the side of their mouth so the nicotine is absorbed by the oral mucosa. This is because nicotine, when it goes into the gut, can cause a lot of nausea. And so countless patients have said, I can't use the gum, it makes me sick. Well, let's review how you're using the gum. Another one of these pearls that's included in the other resources I'll point you all to, another pearl has to do with the nicotine patch. Folks may feel like they can't sleep with it because it's activating. Nicotine, as I said, does all of these things, like making us feel more active and concentrated. And so somebody might want to take the patch off before they sleep. It's also important to remind them that their nicotine plasmin levels will drop, as I pointed out in that image where somebody isn't smoking overnight or getting nicotine overnight. And so they need to be prepared in the morning with something so that they can address those early morning cravings. And so these are little pearls about these very effective medications that are highly underused, that we can share with our patients to get them kind of over the hump of hopefully being able to reduce their smoking. And then the last 2 medications are bupropion and varenicline. Bupropion is very well known in mental health practice because we use it for depression largely. And the medication is usually dosed at 150 milligrams of the SR, which is what it was studied as, twice a day. And at the same time, depending on what the patient has available and what they're able to tolerate, 150 milligrams a day is also effective if they're not able to tolerate more. And the last medication is varenicline, which is the newest medication and probably has some of the best efficacy data. The pearl that I like to share there is that there was a lot of concern about this medication having neuropsychiatric adverse effects. And what we know from the EAGLES trial was a multi-site international trial that compared nicotine replacement, varenicline, bupropion, found that all of those groups had those same neuropsychiatric adverse effects at similar rates. So it was really the nicotine withdrawal in the process of quitting smoking that was concerning. It was just an interesting phenomenon, if I'm thinking about public health, where people were more able to share online, for example, stories about varenicline in a way that they hadn't done for other medications in the past. And so, so that black box warning of neuropsychiatric adverse effects was removed from varenicline, and it continues to be a very effective medication for smoking cessation. So, intervention should include counseling, 1 or more medications. Clinicians should encourage the use by trying to have everybody consider a medication. There's many first-line medications, and combining them should also be considered, because we should, when I have a patient who's ready to quit smoking, I say, yes, this is great. Let's get you everything that you can so you can be successful in that. These are the resources that I will close with. One of them is from the American Psychiatric Association. I'm chair of the American Psychiatric Association Council on Addiction Psychiatry, and I've had the pleasure of putting together this page as well as a cannabis toolkit. This is the RX for Change website, rxforchange.ucsf.edu. Several of the slides and handouts come from there. And then, as I said earlier this year, we were able to put out at the APA, along with the Smoking Cessation Leadership Center at UCSF, 5 hours of free CME on the APA Learning Center. And again, I was delighted and so appreciative that Dr. Andy Saxon was able to do one of those lectures for us. And so with that, I will close, and I would love to have questions or discussion.
Well, Dr. Das, thank you for walking us through these major sections about tobacco use, nicotine, generally treatment, clinical assessment, and really I think up to date understanding of e-cigarettes and vaping, which has shifted, I think, in recent years. It's very informative. I'd like to encourage others to write in with any questions or comments. We do have a couple of minutes to pose some questions here. I don't see any questions quite yet, Dr. Das. So maybe I'll ask you something that I was thinking about during your presentation, and frankly, maybe worrying about, which is a possible cohort effect of adolescents being exposed to nicotine, and in some ways developing a generation with higher prevalence of nicotine use disorder, perhaps throughout adulthood. Is that what it looks like we're headed towards? Do you have concerns about that? And if so, how do you use that, which is thinking many years about the future, to motivate clinicians to act today?
Yeah, that's a great question. I am less worried, and maybe in 20 years I'll regret saying this, but I'm less worried about the phenomenon that happened with traditional cigarettes happening now with the e-cigarettes, because I am hopeful that we are a more informed society. So when traditional cigarettes were marketed, they were the cure-all for everything. They were going to help, the struggling mom, get through her day. They were going to help a doctor have a great relationship with their patient and be glamorous. They were very different compared to what I'm hopeful, as I said, of being more aware. So we already have campaigns like the Truth Initiative. We have information from the CDC where we're just a more aware society. Now, I've alluded to some of these health products, these things that are becoming more fashionable and health related, that are vaping devices that are basically vapes in disguise. I'm concerned about those coming out, and I'm also concerned about cannabis vaping, just because that is, taking us by storm as well. So I'm not worried about this cohort effect. And again, hopefully I won't regret saying this in 20 years. But there is still a considerable concern, because nicotine is so widespread, of young people starting to adopt these and being affected. So while the rates are, in the 10 to 20% range now for e-cigarette use, there is a risk of it increasing over time.
A question along the lines, maybe just of nicotine exposure. What's the current understanding, or what's your view on associations with incident psychiatric illness?
Yeah. So the overall body of research, usually I get the question about the other side is, if somebody has a psychiatric illness, nicotine is as the tobacco industry put it, it is self-medicating to treat that. In terms of the risk of psychiatric illness, there is enough epidemiologic data to say that nicotine can affect earlier onset of certain illnesses, and certainly can worsen the trajectory of those illnesses. It's not as strong as, say, a lot of what I talk about. It has to do with cannabis these days. It's not as strong as, say, the very clear epidemiologic data on cannabis and psychotic illness, but it is there, and it is something that is concerning. So if somebody has depression, they're less likely to be able to cope with that depression and manage that depression if they also are using cigarettes. And so those are examples of what we know well.
A complicated question related to evaluation for solid organ transplantation. Maybe you've thought this through or been asked this question before, but our colleague is asking about a requirement really to abstain from nicotine and tobacco use prior to transplant. What are your thoughts on that? On risk of transplant complications afterwards, maybe, or the ethical considerations related to this?
Yeah, that's a great question. I see a lot of patients referred to my tobacco clinic for this very reason, that they need to get a transplant, they need to quit smoking. And obviously I see a lot of people for alcohol treatment as well, but smoking is coming up more and more. I've also seen that for surgery, some folks want the individual to be entirely off of nicotine products because of nicotine and healing. But it's really the smoke that I am most concerned about. I'd rather have somebody on some nicotine replacement than be smoking. I think that it's usually it's not whose problem is it? I think it's all of our collective problem. And so I think that we just haven't tried often enough with a patient. And part of this is the motivation is like, we need to work on how we're framing this and how we're instituting motivational interviewing. And again, throwing all of the tools at them. It's not enough to just say, here, go get some gum from the drugstore and that's going to help you. We need to really think about, okay, what combination of medications can I do? Can I set up follow-up with you over time so that we stick to this and we're checking in on this? So nicotine can't be an afterthought. It needs to be kind of the main piece of what we're approaching with these patients in treatment.
How long do you typically recommend for abstinence in a circumstance like that?
Usually surgeons are telling me what they need, and that number usually is 4 to 8 weeks.
4 to 8 weeks, I see. Okay. Would you use varenicline in a circumstance like that, or?
Absolutely, yeah.
Okay.
In addition to other things.
In addition to other things.
Yes.
Sure, not to undermine your message in any way. Okay. Yes. Okay. Well, very interesting. I have, here we are just right up to 1 o'clock here. I don't see any additional questions coming in. And so Dr. Doss, again, very, very informative, many different domains, the neurochemistry, et cetera, pharmacology, clinical assessment, treatments, thinking about populations, very helpful presentation. I'm eager to see what continues to develop over the course of the year with your efforts chairing the Addiction Council and working on this presidential theme through the APA. So thank you for joining us today and presenting in this Grand Round series.
Thank you for the invitation and the questions. Take care.
All right, well, take care. Bye.